and good morning to those of you who, like me, are on the Pacific Coast. Welcome to a special edition of our regularly scheduled learning community on intensive in-home behavioral health treatment, or IBHT. The IBHT learning community is brought to you by the National Technical Assistance Network for Child, Youth, and Family Behavioral Health, hosted by the Institute for Innovation and Implementation at the University of Maryland School of Social Work. I'm Eric Bruns. I'm a senior advisor to the Institute and a professor of psychiatry at the University of Washington School of Medicine. Most pertinent to today's event, with others here on our team at the University of Washington Department of Psychiatry and Behavioral Sciences, we're privileged to be the host of the IBHT learning community. For the majority of you who are new to this forum, the IBHT learning community comprises representatives of over 20 states who are joining us to focus on how best to mobilize data and evidence to improve the quality and impact of IBHT services, a critical part of the behavioral health continuum for youth and families. Today, we were scheduled to present the third in our series of presentations and discussions on research-based intensive behavioral health treatment, in-home behavioral health treatment, but we're in a very challenging time, as everyone knows, for all of us in children's services across the country, and most especially for the families and youth that we serve. So the Technical Assistance Network for Children's Behavioral Health really wants to demonstrate that we are there for you, and thus, given our current crisis, we decided to do a pivot. And so to support you in developing your own response to COVID-19 for your team and for your community, we are convening a series of conversations. This edition is indeed a conversation on intensive in-home behavioral health treatment during COVID-19. During this, but if you go to the next slide, just to make sure folks know, we are hosting a series of conversations around this theme of managing now and being prepared for the future. On Tuesday of next week, there will be another conversation about crisis communication during COVID-19. And sometime in the next week or two, we will also have a conversation on mobile response and stabilization services, as well as one on residential treatment facilities and how best to deliver these critical services in our continuum during the current pandemic. So today, you can go ahead to the next slide then. We are going to be talking about in-home behavioral health treatment. And what we're going to do during this session is first, we're going to hear from another key advisor to the TA network, Dr. Christopher Balanci of Judge Baker Children's Center in Boston. Chris is going to talk about telehealth options and other accommodations that may be useful for providers of IBHT, but also other services in our children's systems of care. After we hear from Dr. Balanci, we'll hear from Dr. Richard Shepler of Case Western Reserve University in Cleveland. Rick manages a statewide IBHT initiative in Ohio, and will be providing some IBHT-specific recommendations that have been previously presented to providers in his home state. During the course of the webinar, we invite all our attendees, like Tiara explained at the outset, to use the chat box to do a couple of things. First, any questions you may have for our panelists, including Drs. Balanci and Shepler. We also have Liz Manley from the National TA Network and previously from the state of New Jersey, where she managed the Children's System of Care initiative there. Liz will be available as well. And we're going to do our best after these presentations to respond to your questions. Second, if you have any observations, tips, comments, or recommendations of your own that you would like to share, please use the chat box to do so. Before we get started, I'm now going to let Michelle Boardman, our social media expert from the Institute and the TA Network, tell everyone a little bit about how the resources available from the TA Network on this topic, as well as the information and the resources that we share on this webinar, will be made available to you and to the field. So Michelle, can you let us know about how that's going to work?
Sure, thanks, Eric. So the chat box, as you can see, is going to move fast, and it's hard to scroll backwards since it pops forward every time a new comment is entered. So we're gathering all of the comments in a Word doc, and we will develop a tip sheet after this with some takeaways from this meeting and including links that people want to share with each other. And we will distribute that to everyone who's on today's webinar.
Thank you very much. So with no further ado, I'm going to hand it over to Dr. Christopher Belanci from Judge Baker Children's Center to talk a little bit about some of the telehealth and other accommodations that folks may find useful in providing IBHT and other services. Take it away, Chris.
Thank you, Eric, and welcome everyone. The world and our country are facing an unprecedented crisis as a result of the coronavirus pandemic. And in this crisis, it requires us to change the normal rules around treatment and how we think about the provision of services to children and families. So I guess the question for today is, how can you provide a similar service to children and families while ensuring both your staff safety and the safety of those that we're working with? For instance, if you decide to continue to work in homes, can you do that realistically while enforcing social distancing rules? I guess that's an alarm telling us that perhaps that's going to be a challenge. I was envisioning what it would be like to try to come up with a 6-foot round hula hoop and envision trying to go into a home. You wouldn't make it through the doorway, right? Think about what it would mean if the families have to be anticipating everything that you're touching and then following in your path behind you with a bleach bottle, providing an antiseptic relief or insurance that you're not bringing in the virus into their home. So while it's possible, and there are some ways of operationalizing, continuing to do work in the home, and Dr. Shepler has some guidance from Ohio, and there's some guidance from Massachusetts on ways to try to do this. You know, minimally, you would want to make sure that you're not having staff enter home where someone is known to have a fever, for instance, or has had a known exposure. But as we know, the virus is transmissible even before you're symptomatic. And so there's no guarantee that even if you're not showing symptoms or the child or family whose home you're visiting or providing in-home services to is not showing symptoms, that they won't be exposing your staff to the virus, or that your staff may not be exposing the family to the virus. So if you make the decision to move to a telehealth platform, what does that mean in terms of the provision of in-home behavioral health services or any kind of telehealth behavioral health services for children and families? Well, the good news is that the federal government has loosened some of the regulations regarding telehealth provision, including a loosening of Hipaa as it applies to telehealth platforms. For instance, you are now allowed to use video conferencing platforms that are not Hipaa compliant, and you could even use the simple phone. So for areas where there's a lack of high-speed internet access, or the homes that, or families that you're working with don't have access to teleconferencing abilities, you can actually pick up the phone, and most homes do either have a landline or a cell service, and think about ways that you can try to support the family through a telephone platform. Additionally, Medicaid and Medicare are now allowing for telehealth service provision and reimbursement. And there are some states that are also requiring private insurers to cover at the same rate for telehealth as in-person treatment. So while this is a crisis, there's also an opportunity. And I just want to say that in my exploration of the research on telehealth outcomes, and I'll share some of those resources with you, in many instances, families actually are coming to prefer telehealth services than in-home treatment. So I would anticipate that even after this crisis is over, and we're really talking about a 12 or 18-month horizon, Not that we're going to see the numbers of cases of coronavirus infections or hospitalizations and unfortunately deaths over that long period, but we should expect that there will be flare-ups and hotspots. And so even in areas where you may have liberalization of the social distancing rules, you may anticipate or should anticipate that there could be flare-ups that would require you to be moving back to a telehealth platform. And so I would be thinking about not just managing this crisis in the short term, but also anticipating what this is going to mean for service delivery in the long term. And also anticipating that some consumers are actually going to prefer this platform and this means of support and telehealth. So just to identify some resources, SAMHSA has developed a COVID resources page, which includes training and technical assistance offerings, tips for social distancing, as well as other notifications from the federal government, including the enforcement discretion on telehealth that I've mentioned. The American Academy of Child and Adolescent Psychiatry has both a COVID resources page with useful general information about supporting children, adolescents, and families, and a specific clinical update from 2017 on the use of telehealth as a service provision model for children and adolescents with behavioral health needs, which also has a very nice review of the evidence for those interested. The Technical Assistance Network developed a tidbit on telehealth that was released in December, and we'll provide a link to that resource as well. And finally, the AHRQ did a review on telehealth, which is rather broad and a bit wonky, so it's only for those research-oriented folks, and not specific to behavioral health or children, but does review psychotherapy research as provided through telehealth platforms. So that's kind of just a general introduction of both the challenges and opportunities that we're facing during this crisis. I'm going to now allow Rick Shepler from Case Western to talk about his work in adapting in-home behavioral health services through this crisis. Take it away, Rick.
And can you all hear me?
We can hear you now, Rick.
All right, thanks, guys. So what I wanted to do is go over what our center, the Center for Innovative Practices, and our staff, in collaboration with our Ohio Department of Mental Health and Addiction Services and Department of Medicaid, what we have come up with in terms of communication guidance, guidance in terms of practice, guidance in terms of telehealth, and some other strategies. So I'm just going to walk you through fairly quickly some of the things that have happened in the last 2 weeks, just to give you an example. So, you know, we're a fairly mature intensive home-based treatment state. We've been doing it for over 30 years. This is new, obviously, to all of us. And we utilize we have a supervisor learning community that we convened in an emergency to start to get an idea what folks were doing last week when this was gearing up, while the state at the same time was writing emergency rules. So we had a good idea about what was going on in the community, but also what was going on at the state. So we were kind of the link, if you will, to both. And so that real-time communication was critical because there's so much time-sensitive information out there. One of the strategies we utilize, I'm sure you guys are utilizing, is our staff basically daily, we were monitoring communications from the feds, the state, and providers on a real-time basis. As soon as something that was able to be sent, could be sent, we were sending it out. And then we followed up with learning community for sharing and talking about questions they might have for clarification. Our state did put together fairly quickly emergency telehealth rules that incorporated the Office of Civil Rights Enforcement Discretion document. And if you haven't seen that, I believe that should be being loaded. But that talks about all the acceptable synchronous and asynchronous, their terms, modalities for communicating with families, and their discretion and enforcement are their words around those modalities. So there's significant discretion right now. So once we got that all set up and we started hearing from our providers, we wanted to get an idea if folks are still going out and doing home visits. So that was the beginning of last week. Since then, we have been put on shelter in place in Ohio. But mental health providers, emergency mental health providers, are still able to respond. So we put up some guidance, and we developed some guidance on, making decisions about going out, telehealth being the preferred modality. But if you do go out, under what conditions, and then how do you keep the family safe, and how do you keep yourself safe? And we came up with some protocols for that, which I believe will be posted on the chat. In addition, what the other emergency becomes one of, well, what do we do on telehealth? How is it different than meeting with the family in their home? And so I think there are certain interventions that are more compatible to telehealth. So we started to develop practice resources for clinicians to utilize with youth and families via telehealth. And so, the big question was, how do you keep engagement? Can you do family sessions, et cetera? So we're still learning as we're going. I know, Dr. Beal on our staff has already created a couple of PowerPoints that we're sharing with providers on practice resources. But that'll be ongoing, and we look forward to hearing from all of you today, too, in terms of what you might have learned. And the other thing that we have kept attuned with is monitoring what the families are experiencing through our home-based providers. How are they dealing with the crisis? Are they accepting of the service? Are they doing okay? And I think what we're hearing is something actually very promising, and they're responding to an external crisis by coming together as families in ways that I guess initially was unexpected to us, but we're very encouraged by that. So we want to continue to note all the patterns of family response and coping, and also figure out what are some of the best ways we can still remain available over time. I mean, this includes anything from doing intakes over telehealth. What does crisis intervention look like over telehealth, et cetera. So that is a very quick nutshell of what we have done in Ohio, and I want to thank all the Ohio providers and my staff and our departments for moving at light speed in putting this together.
Thank you, Rick. I'm monitoring the chat a little bit here, as others among our team are doing. One of the things that obviously people are asking is that both Chris and Rick have referenced some useful resources, and it looks as though Tiara has posted, starting to post some of these. These include the ACAP resource on telehealth and the platforms and some of the rules and recommendations around using those. Rick referenced the Ohio document, and that led to a flood of requests to see that. That's now in the chat box as well. And again, as Michelle said from the at the intro, all of the materials and resources are going to be bundled up into a communique that gets sent to everybody's email that was listed when as you registered for this webinar. So I'm going to hand it over now, hopefully this doesn't put you on the spot, to Liz Manley from the Institute and the TA Network. So Liz, what are you seeing in some of the comments? We've seen a lot more comments than questions, and some of these comments that I've seen as they've gone by have been really interesting and helpful. One thing I see here is that representatives of different states, Wyoming, Florida, others, have moved their wraparound and other in-home behavioral support services to phone and to tele platforms, seeing some good tips around ways in which certain kinds of steps in the treatment process can still be done, including taking screenshots of documents that need to be part of the record across the different phases of intervention, and that at least in some states, screenshots and proxy signatures with email trails are adequate, have been kind of deemed adequate to back up the documentation that's needed. So that is very cool, and we can see Wyoming has offered that up as a solution that's being used in their state. Before we get to some of the questions, which are now beginning to show up, please feel free to ask those questions via the chat box. Liz, any other observations or themes that you're seeing in the chat?
Yeah, I think that a couple things in the chat that I think are interesting are really how people have shifted to technology, to use technology as a tool, with some really good suggestions that I think we're going to need to package up and make sure people get. I also think that there was some real big questions around the 12 to 18 months that Chris was speaking about, and planning for 12 to 18 months. Wondering if, Chris, you might want to spend a minute just talking about that, because I think that would help folks really kind of plan.
Sure, I'd be happy to. And I don't want to be overly alarmist in my statements, but as I understand it, we're at least 12 or 18 months away from developing a vaccine, and currently we have no treatment for this virus. So our only way of managing our way out of this pandemic is through social isolation and minimizing the exposure. As we're seeing in places like New York, LA, and even here in Massachusetts, the rate of infection is exponentially increasing by the day. And I think we're all becoming very familiar with the term flattening the curve in trying to prevent an overwhelming level of infection and then healthcare need that would overwhelm our hospitals and our intensive care units and our ventilator supply. By flattening the curve, we are also extending the period where there will be infections continuing for the distant future. There is little clarity about whether or not this virus will act like other influenza viruses, where they go more dormant during summer months. And so I think we're going to be waiting to see what happens as the summer happens in the Northern Hemisphere. There are infections already happening in the Southern Hemisphere, which indicates that this will probably become part of the typical influenza cycle, meaning that we should expect that even if we are fortunate enough to see decreases in infection rates this summer, we should expect to see recurrences happening again in the fall. So my point about 12 to 18 months is we need to be prepared for the ability to provide remote services, not just for the next couple of weeks, but to develop infrastructure that we can sustain these efforts for an even longer window. And you know, the promising side of this is that we're also finding, as I'm seeing in the chat box, kids really, you know, are liking their technology. Families like not having to commute to our offices. I know this is an in-home behavioral health treatment, so maybe it's less relevant there. But, you know, it does involve a certain level of intrusiveness and multiple appointments. And so might this provide an opportunity where our consumers, clients, patients prefer this methodology and prefer the technological approach? Our workers may also prefer it too. And so there's an opportunity to think about and perhaps even gather data on what the outcomes are as we move into this new way of delivering services to children and families. And figure out what's the best practice as we do that. There are some established guidelines. I'll put in the chat box another resource from the American Telehealth Association specific to providing children's behavioral health services.
Thank you, Chris.
You're welcome.
Another theme in the chat box has to do with some of the terminology. It's not really, it's more of a statement around the physical distance versus social distancing. So I think that might be one of the takeaways for this group is around language and how we actually communicate with families around this work. Chris, I did have another question for you. Do you know if they've relaxed the FERPA rules?
FERPA?
Yeah.
It's a really good question. I haven't seen anything about FERPA, but given the fact that schools are closed and schools are trying to similarly figure out how to support children, including those on IEPs or with behavioral health needs, I would imagine there's been some loosening of those regs, but I have not seen any guidance in that way, and perhaps someone else has, and if so, they can chime in the chat box.
Okay, if not, maybe we can research that one, no problem. And how about Hipaa? I haven't.
Hipaa, yes.
Okay.
I already put in the link to that, and I can put it in again because I know it scrolls fast, so sometimes you can lose it, but we'll also make a note of making that available.
Great. Then another question, and this is for the whole panel, is have we had success in getting to places in which there's no Wi-Fi, where families have difficulties connecting? Any thoughts about that?
Well, certainly, I mean, telephone, but you run into issues around, families might have minutes that are allotted and you don't want to use those up. And depending on your state, if folks have smartphones, you can use some of the phone technology as well. But it presents another layer of challenges to work through.
Rick, this is Eric. There was a question also about some of the how, where'd it go? Oh, yeah. What did you mean in your statement about doing intakes and crisis intervention via telehealth?
In our state, we are allowed to do to actually take on new clients through telehealth intake and assessment. But I think that's new ground for a lot of us in terms of, there's an engagement piece to it and getting all the information via telehealth. And I think intensive in-home folks have been doing crisis stabilization by phone for, decades. So I think we're pretty good at that. I'm not sure we've done it through teleconferencing. But it's something we're going to have to get used to, that's all. I didn't mean it as a challenge or a barrier.
One of the, a couple of comments have gone through the chat that there are, that companies have been relaxing some of the rules. If families reach out, they can get more minutes for their cell service. So it might be something just to share with folks. A couple of folks have reported that, so we probably want to start there for families who are having some challenges. I did hear this morning that there are some, in some places like Starbucks and Panera's have opened up their Wi-Fi. If families can be in the parking lot, they can actually access the Wi-Fi from those particular places. And we'll probably add a few more resources that we're not talking about here around how to get families connected in the places in which Wi-Fi is challenging, because we still have some research that's happening on that as we speak. So the next, another question that came up in the chat a bit ago was around, is it, would we suggest that clinicians who are going into the home have additional questions for the family before they go? Do you think that that's a good idea to include questions around whether or not there's anyone has been symptomatic, whether or not people have fever, or do we think that going in the home is not a good idea at this time?
Let me take a quick stab at that, and I'll let Dr. Belanti, take the second volley on it. So we have developed almost like a triaging mechanism around going out at this point. The majority of our home-based teams are utilizing telehealth as the primary and sometimes only method of delivery. But we have some that have made a determination that if, in fact, the youth crisis, family crisis is of such a nature that it would require hospitalization or cannot be stabilized via a telehealth or a telephonic mechanism, modality, that it still is acceptable to go out under certain conditions, but you have to follow a number of things. Number one, your agency is the final makes the final determination on any policy. So we can give out guidance, but the bottom line is the agency, in context of state, county, and federal, at this point, orders will have to operate within, and each of your states might have different exclusionary criteria about who can do what in terms of professions. The couple things that we do ask, we will ask about COVID symptoms with Dr. Belanti's caveat, which is we should just assume that we all could be positive. And because of that, we have a guidance that's been posted that talks about how do we keep the family safe, how do we keep ourselves safe, and we want to pre-structure with the family past the screening questions. Hey, there's some new protocols. You know, you're used to us coming out to your home, but we had to create some new protocols around safety. It's for your safety, it's for our safety as well. And we respect your preferences as a family, that if you do not want us coming out at this point, we certainly understand. And then we could offer other possibilities like, well, would you feel comfortable with us if we met outside of your home and things like that. So, and in addition, we have a bunch of, Rick's OCD sanitizing methodology that we put in in our little guidance letter. But those are some things we ask ahead of time.
A quick question before we hand to Chris. Any thoughts about self-disclosure? If someone, if one of the workers, do they have a responsibility for self-disclosure if they feel like they've been exposed?
My initial answer on the inside was, hell yeah. My answer on the outside is, one would think that would be appropriate to disclose that and not go.
There you go.
So, I mean, you've got to follow the CDC and your state guidelines around that.
Great. Okay, Chris, to you. Do you have any additional thoughts?
Yeah, I mean, I think as I'm reading the news and the scientific literature about the coronavirus or COVID-19, we have to assume that the infection rate is well in advance of the number of positive tests that have been reported thus far. Some estimate as many as 6 to 10 times as many people are infected with this virus than what are currently being reported. And again, the transmission rate can go up to 2 weeks between when that person was exposed themselves and got the virus and before they start becoming symptomatic. I think in most cases, it's probably within 5 or 7 days. but we're still establishing what the science is about this illness and this virus. So I wouldn't want to take on the responsibility for exposing my clients, my patients, without a high degree of certainty or a high need to be in that home. So I echo what Rick is saying. Now, if there is definitely a need for some kind of in-home intervention, I love this idea that Rick had about meeting outdoors. Still pretty cold here up in the north, but it's not, prohibitively cold. And even before this, I used to love going for walks with the kids that I was working with. And there are opportunities, even with some of the children with hyperactivity and impulsivity, to do some interesting engagement outside of the home. So I think this is a time for us to be thoughtfully challenging assumptions about the way we deliver the services. And that's where I think the theme, managing now and planning for tomorrow for this whole series is so important, because I think we're all going to be learning how to do this together. And that as a community, I think we're going to be coming up with new ideas and guidance for the field in real time, and then hopefully be developing outcomes and ways of capturing this knowledge so that it informs the work in the future.
Mm-hmm. Well, yeah, there's a theme in the chat that talks about how folks are still enrolling new families in these intensive home-based services. I know Dr. John Vandenberg, who is one of the founders of Wraparound, has just recently penned a piece about conducting wraparound in the era of COVID. And I do think that first and foremost, you have to follow your local and CDC guidelines. But Dr. Vandenberg's suggestion is that we consider the option of a first in-person contact, especially for families who have very complex needs or are reticent to be involved in team or intensive home-based planning and treatment. And it may be that finding ways to hold that meeting out of doors, ensuring you're following local and federal safe meeting guidelines, ensuring that there is much use of sanitizer and hand washing. It is in fact indoor space. But it very well may be that for us to do our job as best as possible and engage, we adhere to distancing and sanitizing guidelines while also having some sort of in-person interaction, ideally 6 to 10 feet away and perhaps out of doors. During that initial meeting, Dr. Vandenberg suggests that, again, there are certain kinds of things that may very well be best done in an initial meeting in person, such as assessing immediate risks and making sure that there are some of the engagement activities. But during that meeting, there also is a clear communication around what is the preference of the family about ways in which they can continue to work together safely going forward. I believe the National Wraparound Initiative will be posting Dr. Vandenberg's really thoughtful piece sometime in the near future.
Yeah, that's Eric, that was one of the things that the folks in the chat were really interested in, where they could get that that piece, that article. So if we could get that out, that'd be great.
Yeah, it's a nice piece.
Another question is, what platforms are people using in order to communicate? And there's a few that folks have listed in the chat that we'll get out. Some of them include Zoom, they include WebEx, but if you have them, if you can include them in the chat so we can include them in the what goes out to folks, that would be really helpful.
DoxyMe is another popular one.
DoxyMe keeps coming up, so that's great.
Yeah, one of the things, a little trick to think about is sometimes the bandwidth breaks down and it can be very frustrating, like it just happened with Eric when he was talking and the communication broke down. If you shut off the video often that will enhance the audio because I think it requires a different bandwidth speed. So while it's nice to also be able to see the person, it's not always essential. And so being creative, flexible, owning that we're all kind of discovering how to do this work differently, both on the family side and on the professional side. Being really thoughtful that, you know, the background is visible, so where you're doing this from, making sure that you're presenting yourself professionally. There were some jokes before we started about, you know, what people were wearing from the waist down, wanting to make sure that you're kind of professionally presenting yourself. There was also a sharing of a video where someone took their smartphone that was accessing a teleconference into the bathroom with them. That's ill-advised. So just making sure that you're being thoughtful about the fact that this is still a professional encounter and advising your staff about the rules and expectations of that kind of professionalism. Because while it's a very convenient means for engaging for those of us that have that kind of bandwidth speed and technology available to us, we have to be really thoughtful about the ways that we're communicating and conveying the information and what else is being seen and heard.
That's very helpful. We have another question that might be helpful for the group, and that is, what do we do about the worried well who are overwhelming emergency departments? Is there anything that we can do collectively to help in that area?
Yeah, and there was an earlier comment that the federal government worked with some of the IT folks in developing kind of an interactive website where you can go online and put in your symptoms and see whether or not it aligned with coronavirus. And there seemed to be a lot of misinformation and false positives and false negatives, meaning that it wasn't very accurate as a predictor of whether or not you currently had the virus. I'd say the number one symptom is fever. So, you know, we need to remember that we still are in the influenza season. It's also allergy seasons in a number of places as springtime emerges. And so sniffles, cough, runny nose, those are very common symptoms and are not exclusive to the coronavirus. So if there's not a fever, and a fever in my mind is a fever above 101 degrees, then it's very unlikely you've got coronavirus, or at least you're not sick with the coronavirus. You may have been exposed to the virus. And again, 80% of people who have been exposed to the virus have very mild symptoms and don't require hospitalization. So I think the first thing to do would be to call your primary care doc. Don't go to your primary care office. Don't go to your emergency room, but call your primary care doc and advise the families you're working with to follow the same advice. We do not want to expose the healthcare workforce to this virus, which is already happening in significant ways. They don't have enough of the personal protective equipment that is required to ensure their own safety. So we really want to make sure that we don't wipe out our medical workforce as we continue to need them to care for those that are seriously ill.
Chris, this is Philip. I wanted to add another question that someone raised. I thought this was an interesting question. Is anyone providing telehealth services via text message with youth? Can you bill for text messages? Are text messages HIPAA compliant?
It's a very interesting question. I saw some chats about using text messaging for screenshots or taking pictures and then texting consent forms, which I think is a very creative approach. There have been, even before the coronavirus, uses of text messages. For instance, the crisis text line has been a very successful resource for suicide intervention. And I'm sure they're getting lots of calls right now, or lots of texts through the text line, crisis text line. I don't know about the ability to bill for text communications. And there was also something in the chat box about some folks using text and then being able to capture the screenshot of the text to put into their record in some form or fashion. Again, the rules around HIPAA compliance have been loosened significantly enough so that HIPAA wouldn't be the limiting factor. But I think it's a little bit in the gray area for me in terms of whether or not that would be a reimbursable service, but perhaps others know.
So, in Ohio, a pressing question right now. We passed emergency rules that incorporated the Office of Civil Rights enforcement discretion policies around HIPAA. It's my understanding of this morning that in Ohio we can indeed bill for texting, the time that's involved in the texting conversation and things like that. But I think it's going to be very state specific in terms of each state's rules, number one. Number two, texting is particularly vulnerable because you don't know who's on the other side of the phone necessarily, because there's not voices. So I would take some precautions into identifying who's at the other end somehow with maybe some code words. If you're going to do that, keeping in mind that texting won't be HIPAA compliant without very specialized encryption post-COVID. And so, we can do it now. We want to keep in mind that follow your state rules about billing. The other thing is it's really critical to have informed consent about any telehealth modality that you're using. And so here's the risks. We're using something that is not typically, that could have some risk to it in terms of information getting out when we don't want it to, or whatever words we want to use. But we need to be very open about the risks of whatever modality we're using with the families, and they have to agree with it, getting verbal consent on that.
Yeah, there was a question about getting consent for telehealth or telehealth services. And in our clinic, we did specifically send out a request with all of the disclaimers around the technology, although we are using Zoom, which is a HIPAA compliant platform. And I think we got back all but one eager consent response. Now, families are in turmoil, so it doesn't mean that we're having the same number of sessions that we might have previously had before the virus, but I think that will evolve and change over time as the need continues and this becomes a prolonged period where people are having to shelter in place or self-quarantine or isolate.
Okay. So there's a couple of themes that continue to go through. One is that one theme that I think is important is some of the strategies folks are using to address the idea that there's just a tremendous amount of loss right now, and people are grieving. They're grieving for the loss of life, but they're also grieving for how things are really different and changing. And I'm wondering if the folks on the panel might have some thoughts about other strategies besides mindfulness was talked about, but if there were other ideas that you might have.
Well, for me, it's a bit of a loss of control that I'm struggling with. So I'm personally managing some of my own anxiety and distress about what I'm seeing and for the people I care about and the families I work with, by just trying to keep order in the areas that I do have some control over. So I know I'm trying to keep to a schedule. I'm trying to be careful at the end of the day when I think about whether or not I'm going to have a drink with dinner or how I'm going to settle myself after a stressful day that has increasingly been starting at 6 or 7 a.m. and running till at least 8 or 9 p.m. And through the weekends. While I support the teams that are supporting the children and families that we work with. And look for small successes. Take periods where you do shut your phone off and ask your colleagues to cover for you. Try to go for a walk. Walks are still allowed, even in the areas where there are so-called quarantines or social isolation. I believe they're still allowed to go for a walk so long as you're following social distancing norms and keeping at least 6 feet between you and any other people. There are lots of online and free yoga sessions, meditation resources. So using some of the mindfulness strategies that were referenced, both for yourself and for those you're working with, you know, and still try to find some opportunities for joy. And in the immortal words of Mr. Rogers, you know, look to those that are helping, and many of those are the people on this call. Find ways that you can gather strength from each other. Use some of the mobile technologies to support your team. You know, our team had a virtual happy hour. So finding ways to sustain the workforce, and particularly given the fact that, you know, I have every expectation that we're really talking about months, not days, not weeks, but a long period in which we're going to be having to adapt our practices. And so how do we sustain ourselves through that period while we support the families and young people who we work with? I think that's going to be really critical.
Thank you, Chris. I do want to just say from the TA network that, number one, we can see through all of your comments how much people are really struggling and yet doing some pretty remarkable practice right now. I wanted to let you know that we're here to support you and support you in this practice as you're looking for new ways to do this work. But just wanted to put that out there for you right now, since it's coming up around the focus around what to do next. And I do think that one of the challenges that we will have is not just what happens when things ease, but that the grief that comes because people haven't been able to be together in the grieving process and loss is going to be really important for us to be attentive to. So that's my comments on that. Let's see, there are quite a few comments around using, you know, really focusing on stress management and coping and finding ways to take care of yourself. So any way that we can help you with that, we're really interested in being able to do that. Are there other comments? I did see one comment, Chris, while you're here, we wanted to talk about children and families with intellectual and developmental disabilities and whether there are specific strategies for them. I can certainly help with that as well.
I'm sorry, directing that to me?
Yes. You want to start? I can help.
Sure. You know, I think we would want to still be able to provide the same level of support for those with intellectual and developmental disabilities, but we're going to have to obviously adapt, particularly for the young people who have verbal comprehension challenges, since the medium really forces more of a verbal interaction. That said, I do know that I learned this morning that Zoom has this ability to, it's called annotate. So you can actually draw with people in the Zoom room. So that's another kind of interesting adaptation of the technology. I don't know whether or not that's available on some of the other platforms. I would imagine a lot of the work with children with intellectual disability and developmental disabilities are going to be with the family and with the parents and with the caretakers. And so finding ways to engage them, support them. If there's a way that if there are two caretakers in the home, if one caretaker can be with the child while the other is meeting with the clinician to problem solve, troubleshoot specific issues. I think that's a really important way to ensure that we're keeping them fresh. As hard as this is for all of us, for the families and the parents who are trying to ensure that their children are kept physically safe and they're home from school, and they may not have the ability to do distant learning and Google Classrooms, it's really, really challenging. There are some resources that have been developed and are being made available. I know Sesame Street has been doing some really great work, and finding ways to use some of these platforms to support the children and families would be my direction.
Thank you. And we do have some feedback from one of the partners in New Jersey who said it's important to keep structure, use visuals, picture schedules if needed, social stories. Thank you, Karen. I think you're right about all of that. There's another question about, has anyone developed any virtual support groups? And if so, could we talk about that? I was just on the phone today with one of the states that is developing virtual support groups using Zoom, and they've had some pretty good success with that. We're happy to share more resources around how families can connect. There's a lot of different ways, including Facebook, using the messaging section. You can do a closed group on Facebook as an example, and there's some other examples that we have to share for you in the resources that will be coming after. Let's see. We also.
I would just add, I think parents really need the opportunity to talk to one another, and so creating those opportunities is so helpful. You know, and they're going to come up with strategies that we may not even think about, and ways of problem solving and sharing successes that I think will be incredibly important. And so using those mobile technologies to support parent groups. So you can have Zoom platforms, and somebody earlier mentioned that even the free Zoom platform is now allowing for a higher number of participants per Zoom group and going beyond 40 minutes, which was initially the limitation for free Zoom. And so, you know, I think the IT world is also trying to step up to the crisis and being creative in allowing some of their technology to be used in a free platform and free service.
So one of the things that we talk about as you're working to innovate, I think is really important to keep track of your innovations, and not only your, you know, how you're innovating, but what's the impact? Is your group expanding? Do you have better engagement? And can you track that so that in the aftermath of this, we can make suggestions about what also can be included and what successes that you've had. So if you can keep track, and we're going to try to figure out a way to get some of that information out into the field as we grow and expand. We have a few more questions. One is, do we have any information for working with unaccompanied youth, transitioned age youth, young adults living independently but with intellectual disabilities? So that's a great question. Chris, you want to start on that, or you have thoughts?
Yeah, the Children's Bureau did put out some guidance to child welfare directors about particularly transition age youth. Some of the youth that have been able to successfully attend college, as colleges have sent their students home, many of these young people didn't have homes to go to. And so thinking about their specific needs and ensuring that they have homes, that they're not suddenly being made homeless, and for transition age youth who aren't in college, ways of supporting them. And I'll look for that resource and try to post it as well.
Great. So someone misses baseball. I think a lot of folks probably do, Russ. So you're not alone. We're here with you and trying to get through that ourselves. It is helpful that ESPN is showing some old sports games. That's been helpful for me, for sure. Do you have suggestions about providing home-based care during COVID to individuals that are currently living in recovery houses with many other people? Either you or Chris, maybe, or Rick, do you have any thoughts about that?
Well, that's not, so that you basically were talking about doing a community-based intervention in a group living situation. So that would fall outside of what we've developed recommendations on. I would be highly concerned about group living situations because it seems to spread quickly in those kind of situations, and I would be highly reluctant to do that, but I understand the question. I don't know, Chris, if you have any other advice on that.
I'm sorry, I was looking up the Children's Bureau resource. Can you repeat the question?
No. So it's about providing a community-based going out and providing a service in a group living situation like recovery houses. And I said basically that intensive home-based, we really don't address that. That's not what we do. But I would be highly reluctant in a group living situation based on the transmissibility and the unknown of who's in that home and of going in there. That was my comment.
Yeah, okay, and I would just agree in the sense that I think the same rules apply. You know, at this point, you have to assume that you can be a transmitter of this virus, or your staff can be, even in the absence of symptoms. And so that's what's so vexing about this this viral contagion in this pandemic, is that you can't simply assume you're safe if somebody isn't showing symptoms. And so I think there has to be a really high threshold for exposing our clients and our patients, our families, and our staff to be in the home. And whether that's a congregate care setting or otherwise. We will be having this conversation coming up as soon as next week. We're still working out the timing for it regarding residential treatment centers. And so I'd stay tuned for that announcement, because I think we'll be talking more about how to manage the potential for contagion in those treatment settings. And in those settings, you know, we have young people who, because of their behavioral health needs, are unsafe to be back in the home. We have inpatient facilities for children that are closing, particularly if they're in a general hospital setting. So we're going to have a critical issue around capacity to support young people with the most profound behavioral health disorders. And I think we're going to, again, have to be pretty creative about how we're going to support that. I don't know, for those of you who are in the child welfare space, if you're starting to get reports of foster families asking for young people to be taken out of their home. I know we had one situation that we were supporting a foster parent with a very challenged and challenging young person with significant aggressive behavior. And that pre-adoptive mother actually had to make the difficult decision that she could no longer support that child being in her home. I expect that as this school closure period extends and in-home mandates are prolonged, we may see further placement disruption. And that's going to be a real challenge, knowing the limited capacity we already have in most foster settings.
Yeah, so it sounds like this is an ongoing topic that we're definitely going to want to be talking about. So the residential discussion, I think, will be helpful for folks, and resources as we find them. We'll be happy to share them around what to do around the placement issues and how do children get both a safe living environment as well as get the care that they need. There was a question in here or a comment that some children's residential providers are using headsets for youth to communicate with the parents privately from their rooms. So that's quite a good idea, I think, in ensuring that communication is still happening between children and families is just really important. Shifting gears a little bit, there was a question around Medicaid paying for phones for individuals who don't have a phone. And I just wanted to reiterate that is, someone actually reported that 211 will allow or connect to that. I think that's probably depends on where you are, so we'll try to get some information out around that as well. Someone wants to know if the chat can be sent to participants. We're going to try to wrap the chat up in a way that it's helpful to you, pulling out all of the information. Somehow I feel that's my job. So I'll be working on trying to get the most relevant information from the chat to all of you so that we can make sure that you have the most relevant information. Let's see. Can the series of WebEx invite be shared to future attendants? Yes. Can the series WebEx invite be shared for future attendance and the crisis meeting discussed earlier? Yes, it can. And we'll not only be sharing that in what goes out, we'll also be, that will be publicized in the TA Telegram. If you don't get the TA Telegram, it is a really great tool. You can get that you can sign up, I believe, on the Institute's website. That's the Institute for Innovation and Implementation at the University of Maryland. Let's see. Lots of folks think that the information has been helpful. We're happy to share all that.
Liz, can you hear me?
Yes.
This is Rick. I just wanted to make a few other comments. I think that in terms of our work with youth and families right now, there's the COVID crisis, and then there's going to be the financial crisis. And so we have to pay close attention to the basic needs of families, particularly, housing in particular. And so how we intervene, what we intervene on, the content could change, okay? And so we need to pay attention to that. The other thing I just need to make a point, and that is, I think this is also going to highlight the vulnerability of mental health providers in staying afloat in a time where you may not be pulling in all of the dollars that you need to because the modalities have changed. And I think it's going to highlight the vulnerability for agencies and how they stay afloat as well. And so I think it's a time for us also collectively to be good advocates federally around how this impacts us so we can still be here in a year and a half.
I think that's an excellent point, and I do think that's why it's really important for us to understand what's working, how it's working, and who it's working for so that we can advocate for those things to be reimbursable as part of the long-term strategies for states and communities, for sure. I do think that the financial concerns are a lot of folks are really worried about those things, and we're going to need to have some, I think, complex conversations regarding those moving forward, for sure. Go ahead.
There were a lot of, there was a lot of money in $2 trillion support that was passed by the Senate and is now heading to the House and likely to be signed by the President. Included in that is another $500 million for SAMHSA, $100 million for extension of broadband network in rural areas. So hopefully this will build out a furtherance of our infrastructure to support the behavioral health needs, not just during the crisis, but hopefully beyond. And, I do want to be orienting ourselves both towards managing the day-to-day, which is really completely overwhelming and consuming, but also thinking about what happens after we do see the peak achieved and we're coming down in terms of the numbers of people infected, and we're starting to think about a life beyond the coronavirus. I think it'll be a different landscape. I think it'll be a different landscape in terms of how we do our jobs, how we use technology that we've become so dependent upon so quickly, and also how we rebuild our economies and our child and families' lives and get back to school, get back to work, and get back to good behavioral health care. And I think there's going to be a lot of success stories and novel approaches, including all the ones that people have been offering up during this call. I'm just so impressed by the innovativeness the folks and the participants. We have over 600 people, so clearly this is an issue that is of extreme relevance and importance, and an opportunity for all of us to come together and really write the roadmap for something that none of us ever anticipated that we would be doing or engaging in. There is opportunity for hope, and I know one of the things that I try to do to care for myself through this is to look for some of those signs of hopefulness. And I just love the story about people in the crafting community making masks for healthcare workers, knowing that there's such an extreme shortage. Masks that can be washed and reused versus the masks, the N95 masks that are in such short supply. Those kinds of things, they're not just enduring, they're not just helping to orient our communities to the so-called war footing that we've been talking about in society and in the news, but they give us a sense of agency at a time when we feel so helpless and hopeless. And so I think they're actually therapeutic. And I would continue to think about ways that we can discover new approaches. So I don't have a sewing machine. You wouldn't want to wear a mask that I made. But maybe there's other ways, such as just sharing, some of my insights as I'm doing during this call.
That sounds great. Thank you for sharing that, Chris. We have Laura Kenny wants to hear from Hunter. So Hunter, did you want to say something? Let's give you a minute to share anything any of your thoughts.
I don't know if Hunter is still on. I don't see her smiling face on the videos. Hunter is our wonderful research assistant here at the University of Washington. So great to give her a shout out. Hunter is awesome. And yes, let's indeed recognize her in her absence. We're nearing the end of our time together. And I do think that a couple people have commented, and I think kind of made the point that both the text thread as well as just the nature of this conversation really does emphasize how many unanswered questions remain about telehealth. These questions about whether you can be reimbursed for text messages, under what circumstances, phone is and isn't allowed, whether or not there's any Hipaa concerns about virtual support groups. My suggestion is that we find ways to tap into this and some of the other conversations that the TA network is hosting to really get definitive, or as definitive as they can be, recognizing that different states have different modifications to their state plans that may vary from place to place, but the federal government is trying to provide guidance to states around what kinds of modifications they can make to their state plans around some of these things. So, I am in the same boat as a lot of folks here. I would like to know, I have observed just in the last couple of weeks that adolescent clients seem more willing to engage by text than they were in person, or by phone, or by video. And that is something we just have to recognize as part of the kind of generational/digital divide here. So there are grains of learning that we can get out of this. But then indeed, if we find ways to leverage that kind of therapeutic, clinical, as well as social connection for positive results, how do we get paid for it? So I do think that as folks are asking this question, the TA network, if we don't already have one planned, needs to bundle up answers to all the questions that are being surfaced from these conversations. And you might want to go ahead and, Sarah, put up that slide real quick about what the upcoming conversations are going to be as people start to sign off here. There will be continued conversations, and I'm sure there's at least one that's planned but not yet scheduled. And you'll also get some contact information from us here. But there you go. So next Tuesday, crisis communications and what are best practices there, mobile response and stabilization, as well as residential treatment. We've had a lot of questions about institutional care. And again, I think that the thread in our text, or in our text box, chat box here, will inform some of the content that needs to be in both of those conversations. But Michelle or Liz, do you have any knowledge of whether, now that we're a couple weeks into this crisis, whether some of the more common questions might be the focus of some Q&A from the TA network, especially around telehealth? Are we going to have a telehealth specific session sometime in the next couple weeks?
So great question. We have some guidance that's coming out around telehealth, and I think given what we learned today, I think we will have a special session around on telehealth for sure. We'll get that. We'll work to get that scheduled as I go through the chat, and I plan to, Eric, I plan to go through the chat and pull out all of that information to make sure that we hit on all the things that people are interested in.
Thanks, Liz. This is Michelle, and we've done a state-by-state scan of telehealth guidance during COVID-19, and we'll be launching that on our website on Monday with a clickable map, so you can easily find your state.
That is a great thing to know, Michelle, and that seems like it might be just about the most important resource we can provide in doing that work for folks. Summing up some of the themes from across the states, you know, for a national kind of perspective might be useful as well. Another thing that occurs to me as someone who dwells in the wraparound world is I didn't see a whole lot of discussion in the text, in the chat box, although I did have to go help my daughter meet a need for about 10 minutes during the conversation, so apologies for cutting out. Was peer support, and I would be interested to ask and wonder whether or not there is going to be a something on the topic of, given just how much support people are needing at this juncture. I know, for working closely with Allegheny Family Network up in Pennsylvania, with many dozens of parent peer support workers, they have flexed quickly to providing tele and phone support, being proactive about reaching out to all their families, reaching out to school districts around making themselves available to families who may be struggling during this time with kids at home, kids with complex needs. Peer support and the role of peer support could be a great thing to include as well. Any closing thoughts from our panelists? You see here all of our names and email addresses, and we do invite all of you to write to us. I believe there's probably also a TA network kind of hotline email that I don't necessarily see listed here, but if you do write to any of us, we'll certainly get that information to the TA network as a whole for rapid response, which is, as a lot of you know, something that the TA network does.
I have just one comment, Eric. I just wanted to thank people for joining and to let folks know that we know that there's a lot that's happening for them, and that we are thinking about all of you, and we're here to support you as you take on these challenges in the day-to-day. So thank you.
And thank you all for the positive reinforcement in the chat box as we conclude here. So be safe, follow those physical distance guidelines. One of the things that I have heard elsewhere, and that was reinforced by our friend Chelsea from Oregon, is that we are not socially distancing. If anything, we want to be socially as well, if not better, connected during a time of crisis. So let's physical distance, but not socially distance. Take care of one another and ourselves. And thank you all for joining. Be well.